Okay, now the session is open for questions. Two great presentations. One on ovarian transplantation, the other one on ovarian stimulation. New things, new concepts, good results. So I will start. Stine, first of all, at your center, up to what age women oncological patients can be admitted to the ovarian tissue cryopreservation program?
Yeah. So yes, it's all about age, also when we talk fertility preservation. And we do have a guideline saying 35 years, because then we know this procedure will be it won't be very efficient because the follicle pool is so small and the quality of the follicles will be, or all sites will be really
And
small.
what about if a woman of 36 asks for this?
And as I didn't show you here, but we do have a lot of, we have about 9% of our cohort, which is about 35 years of age. So we do take them because one thing is chronological age, but the ovarian age can be very different, or it can be much better. So therefore, of course, if she has the right markers for better ovarian reserve according to her chronological age, we'll still preserve her tissue, yes.
Also because preserving ovarian tissue, or anyway, preserving fertility may have a psychological impact on patients.
Yes.
We had patients who underwent the fertility preservation program despite they were 40, but I mean, it was so helpful for them in those days. They underwent surgery for breast cancers and so on. They thought to the future of a possible motherhood instead of,
and thank you so much for highlighting that, because I think right now we're talking about whether or not it's cost efficient, because not a lot return and we have to wait for a long time to figure it out. But it's actually, this is a very good point, because this is also part of the package, that at that point in that time in their life, this is making a huge difference. And this is giving that psychological mindset that they're going to survive. Someone offered them that they're going to have fertility preserved because we think they're going to survive and make use of it. So this has an immense psychological impact at the time. Yes.
Thank you.
Good point. Thank you.
Thank you. I have to limit my several questions just to two, or one if you prefer. But the first one is just a curiosity, really. If in the transplanted ovary, the number of follicles that are naturally recruited monthly is the same that one of the normal ovary from healthy women that was never ovarian transplanted? Because if yes, it means that there is a different set point for the ovarian recruitment in those follicles. But I don't know.
It's a very good point. Doesn't work too much. Okay, it's a very good point because we can't really study that. But I think because it's so consistent when we see the endocrine function returning, that it seems like it's a normal development. It's not accelerated in any way. And I think sometimes we do see endocrine function coming back at 3 months, but then it might be like secondary follicles which were surviving within the tissue. So I don't think we see any huge differences compared to normal follicular genesis. So it seems like it goes back and it behaves normally. So, but still we don't know. So you might be right, there might be some effects.
Thank you. And the second one is related to the role of the medulla in routing the follicles and maybe supporting the maturation of the follicle. We were fascinating watching your picture where the follicles...
I think this is just very basic biology, but you have the resting primordial follicles in the outer cortex, and then they get activated and they grow inwards. And then you have those big follicles with like growing stages hanging around, and they affect each other. And then in the end, the big preolatory follicle grows out and ovulates. So it's a very dynamic, extremely dynamic system. I think a lot more of it is really this paracrine signaling between the follicles that we can't really study that much, actually. That's really affecting how these, I don't think it's a wave of follicles. I think you're completely right. This is continuous recruitment into that growing pool, and that growing pool is just like sometimes you have a lot, sometimes you don't. It's extremely dynamic. It's not like 10 follicles each day. This is something that's extremely dynamic. And this is also why you get different responses with your stimulations.
My personal opinion, but I could be wrong, is that the primordial and primary follicles which are recruited to grow are those follicles in the ovarian cortex just close to the medulla.
Maybe.
And for some reasons, they are recruited by, surrounding cells.
Yeah.
And that's why when you very simply perform an ultrasound scan, you will see that the antral follicles are not close to the periphery of the ovary, but they are just 2, 3, 4 millimeters below where there's the medulla.
Yeah. And I think this is there's no really, so for the preantral ones, they are not connected to the bloodstream. They don't have theca cells yet. So there's no direct link between circulating FSH, LH, and that little follicle pool, but they might indirectly be affected by those follicles next to them.
Yeah, but this
so
is
this
just
is it. Yeah.
But this is also to underline that, if you did not find the FSH and the LH receptor at very early stages, who cares?
We found FSH.
Yeah, you found
So
the
I
FSH,
think
but not the LH.
it is
But
necessary.
in the end, who cares? We have not to look at single isolated cells, we have to look at the tissue entirely. Yeah? Okay. Question from the audience, please, Natalie. Microphone, please.
I have a question for Steve, and it was a very beautiful presentation. I was wondering if you tried to pre-treat the cortex fragment, or what do you think about pre-treating them in order to awake the primordial follicles before grafting the...
Yeah, excellent point. And there was a lot of studies going into that in the beginning of the whole follicle activation story, because this was what they did in the Japanese study, that they actually activated the tissue before they transplanted, and then they saw some follicle growth. And we tried to replicate, and there's a lot of studies trying to replicate that. And we don't really see the same effects with these inhibitors, and we do see some damaging effect actually on the growing stages of follicles. So we have tried it, and we've tried to do the incubation before and transplant it to mice with human tissue, and we didn't see this global activation that they have seen in the mouse studies. So we can't seem to replicate it in the same degree, and we can get some follicle activation, but there's also a lot of damage to these growing follicles. So it's not, we have kind of abandoned that approach because we couldn't really get it to work, and the studies that are right now, even animal studies, have also abandoned this approach. So but maybe we're just not pushing the right buttons, and maybe it's a lot more complex than just pushing one button with one inhibitor. It needs to be more aspects to this. But it's a good question, yeah.
Thank you. Boris, you talked about the so-called PPOS, which stands for progestin primed ovarian stimulation. And at the beginning of the story, more or less 10 years ago, the PPOS was designed with the use of progestins since day one of stimulation. But then you came with the theory, with the possibility of the so-called flexible PPOS, which means that you can introduce progestin from day 7, day 8, or when the leading follicle is larger than 14 millimeters. And now this is the standard in many centers. And when you published that article, you used just progestin to control the LH surge. But now I see that you're using a combination sometimes of progestin plus generation antagonists. Why this? Are you not confident anymore on progestins?
So, great question. I tried to address this during the lecture as well, but yeah, thanks for the opportunity to clarify. No, I'm even more confident in progestin than 10 years ago.
Yeah.
Because study after study, it shows effective. But there are, like patients who are under risk of relatively higher risk of premature ovulation. Older patients decrease reserve. So even if you use antagonist or even if you use progestin, sometimes they ovulate, right? So as I said, progestins work through the hypothalamus and antagonists work through the pituitary. So for those patients, in theory, the combination may be more effective, but we need data. Okay, so with advanced age decreased reserve, that's what I do nowadays. But these ones, not all of them had few follicles, not all of them were advanced age. But so these random starts at different times are really like different protocols. So if it's not about a confidence, but I just want to make sure I took every precaution. If anything goes wrong, then we wouldn't have second thoughts. But normally, I mean, I think you can go with only one of them.
Yeah, I got your point. I mean, I try to expand for younger students here. I mean, when the generation antagonist is preventing the LH surge because it is a competitive inhibitor onto the GnRH receptor at the pituitary level. Sometimes you have premenopausal women with a reduced ovarian reserve. They have high FSH, high LH, high pulsatility of the GnRH pulse. And so the production of endogenous GnRH can activate the GnRH receptor. And that's why sometimes you have spontaneous ovulation during the GnRH antagonist treatment. Right. However, for progestin, that's my opinion, of course. Progestins, I mean, you can increase the dose. For those women with reduced ovarian reserve, you can simply increase the dose of progestin, and maybe you can be sure to suppress the GnRH pulse generator.
I think you're young. I mean, you're right again. So I got an email from a colleague once from Israel. So they said, listen, we were using 15 milligrams a day MPA. And then the patient, the follicles didn't grow properly, etc. I said, listen, I mean, the patient is most likely now hypo.
Yeah.
Right? Because you probably, it should be dose dependent. So the hypothalamus is too much suppressed.
Yeah.
And so the response they were defining is exactly like, what happens when you stimulate a hypo patient with FSH only.
Yeah.
Right. So her endogenous, they didn't measure her endogenous LH or FSH, but the follicular dynamic was hypo with stimulated with FSH.
Yeah.
So again, I mean, it's worth trying. Women at higher risk of premature ovulation can be given maybe gradually increasing dose of progestin, because if you give it at the beginning now, you will be suppressing too much. Again, I mean, we are learning, all the time. So you can do combination, you can do, dose response. So these ones really, these are improvised cycles. The principles we try, but I mean, we didn't do, hundreds of these cycles. We did not compare, them properly. So that's, just taking a bit too much precaution at the beginning. I think, you just use one of them. Let me ask you one thing then, by the way. I saw among, women with decreased reserve and, decreased, say, low response, say there's like 3 follicles growing. Sometimes, when they come on the day of a collection, you see, one of them has ovulated, the other 2 are still there. Right? So then how do we explain that happens? But I mean, it happens.
Do you think there's the possibility of mechanical ovulation? I have some cases myself, when ready to perform the oocyte retrieval, with pushing with the probe, I saw with my eyes the ovulation. Yeah.
In my life. The other thing I think is, not every follicle has the same responsiveness. Okay, so in these stimulated and suppressed cycles, a late surge, even when it happens, so it's not a proper surge. It's attenuated, it's, whatever it is. And not every follicle has similar number of receptors, similar responding potential. So maybe, the one with more receptors, the more potent one ovulates, the other ones remain. But we'll learn.
Yeah, but next time you see a case like this, please measure progesterone and LH. to understand whether it's a hormonal ovulation or something else?
You can, but you recognize this at the time of egg collection.
Yeah.
So the search should have happened, maybe 36 hours ago, maybe 48 hours ago.
Okay.
So LHV would be probably low.
Yeah.
And the progesterone, as she ovulated anyways, would be probably high. But yeah, let's observe and see. I mean, let's accumulate the data and see what it tells.
Yeah, but I have some cases like you said. So you have to plan a PGTA cycle. So you do not need a fresh embryo transfer. It's not your intent. And you can plan the ovarian stimulation. What do you choose? When to start?
If the patient has proper reserve, okay, then any time is good as any other time. So I ask the patient, I mean, whenever is good for you, like 2 weeks, you can spare time. Then if she has a choice, we start at that time. Otherwise, however they feel comfortable. So patients read a lot on Google, right? And then, most colleagues recommend starting on day 2, day 3. It's so ingrained in the culture. When you tell a patient that you can start, that she can start anytime, she's like,
Confused.
are you out of your mind? I mean,
Yeah.
anyway, she starts questioning it. Then I say, listen, you don't have to start anytime. If you want, you can start at the beginning of your period. But if you want, you can also start anytime.
Yeah.
So that is it. And then, depending on the time, I'm always for simplicity. If we are starting right before ovulation, it's like late luteal phase, I just do gonadotrophin only, mostly. And then monitor progesterone. If it's fine, if she reaches maturity while endogenous progesterone is high, I would just give gonadotrophin and trigger. Or I would add progestin or antagonist towards the end, because that's easy.
I personally think that the best phase of the cycle is the luteal phase.
For a woman with decreased reserve, I mean, if really you need to maximize the oocyte yield from 2 to 3, from 3 to 4, the best time is, I agree, mid-luteal is the best.
Yeah, I think so.
There are 2 questions from the audience.
Please.
Yes, Borinho from Germany. I had a question on that for you, Professor Atta. The patients you presented, the examples for the random start, are mostly very good follicular recruitment from an even moderate AMH, I'd say. And I noticed, I think every patient you had a double trigger with, well, it varied sometimes even 10,000 units of HCG adding to the GnRH and iodine. Can you comment on that, the why and the...
Sorry?
I don't think it makes a difference.
You don't think it makes a difference doing double or single?
It's the release policy.
Okay.
To use it. But secondly,
Yeah.
so even though I don't think it makes a difference, so we were together, was it last year in India?
Yes, it was.
So I was giving a talk on it. Again, I reviewed the whole literature.
Yeah.
I'm not convinced that it makes a difference.
Yeah.
Okay? But despite their limitations, before, after studies, etc., some studies suggest it may increase, maturation rate or fertilization rate. Okay? So then, how do you make a decision? This is how I make a decision. So what does it cost? What is the risk? What is the potential benefit? So the double trigger is something so inexpensive. So the risk is, unless there's risk of OHSS is absent, there's no risk. Okay.
Yeah, but still, there was a few patients, 17 follicles, I think, and I was wondering about the women because I personally don't think it makes a great difference either. But 17 follicles, I wonder how they felt the week after regarding to the ones that only had a single trigger because they will have been probably in more discomfort.
So these people, I mean, if you saw the estradiol levels, ages, really unlikely, nobody had OHSS. So the way I handle dual trigger thing is, I mean, no risk, very little additional cost, maybe some benefits. So, I mean, you can use it if you want for everyone. If you're not using, I can't say it's wrong.
No, I agree. But the different dosage, there was 10,000 and 1,500 and then 6. So I was wondering how you chose.
Really, the HCG dosage,
Yes.
even when it's used alone, I mean, if you look at the history of stimulation, there's not a proper dose finding study. So some countries use 5,000. If you go to England or Japan, or in Europeans use 10,000. And the best study that I could find close to a dose finding study was a retrospective. I think so 2,500, 5,000, 10,000. So 2,500 looked a bit low in terms of maturation rate, but I guess 5 to 10 is more or less similar. Those are all, again, depending on the physician of the day is arbitrary choices.
Yeah, no, I agree. I agree also with the hyperstimulation and with nobody over 3,000
But
picograms,
if I doubt anyone has the smallest risk of hyperstimulation, I wouldn't give any HCG at all.
Yeah,
Zero.
sure. Yeah, but the same thing, but we come from Germany, we don't do a lot of freeze-all cycles because only for oocyte preservation mostly, or for OHSS. So we don't do a lot of dual or double trigger. But I notice in the patients you do, they mostly have to go to work and everything. They will feel very differently the week after the pickup for a week if they had HCG or they haven't. It makes a difference on how fast they go back to routine. So I just wanted to know your opinion. Thank you very much.
Pleasure.
Please.
My name is Maria Ascher from Germany. I've got a question concerning the dose of the stimulation medication you choose. Do you choose it differently in the different times of the cycle? So do you take a different dose at the beginning of follicular phase or at the end of luteal phase, or is it round about the same?
So it doesn't depend on the time of the segment of the menstrual cycle, and I think those doses are really too high. Again, it's got something related with the local practice and clinics policy. So in my own practice, so my choice is to overdose a little bit rather than trying to adjust. Because whenever you try to adjust, the risk is underdosing, then the patient may not maximize her potential.
Microphone.
I don't know what's wrong with that. At the end, so 450 is probably high. So I guess you can stimulate anyone with 225 or 300.
Okay.
But that's a different talk, but people excrete FSH at different rates.
Mm-hmm.
So I think it makes sense to monitor FSH levels. I don't know what's the optimal level, but you need to monitor it because I have patients. You give them 300 units, and in same BMI, you measure her FSH, it comes back 9 units per liter. Similar BMI patient, you give her the same dosage, you measure her FSH level at 7, it comes like 15 units per liter. Right? And then the responses may be different, so we are running a study on this to, if there's a way to calculate this. But I choose to overdose a bit. So in my own practice, it's just like 2 dosages, either 225 or 300.
Okay. Thank you very much.
But it makes sense to monitor.
Okay. Thank you.
Yeah. Very good. Please, second row.
Clara Luvink, Verona. Thank you both for your speeches. I wanted to ask something to Dr. Christensen. I'm sorry if you maybe mentioned it and I missed it, but is there a situation where you prefer selecting the whole ovary, the ovarectomy, to cut out instead of cutting out only a part of the cortex? And if then why and when? Thank you.
So the cortex biopsies we only did for the in vitro activation study. So we normally take a whole ovary because this is high-risk patients. They're going to go through some chemo or radiation that's going to have a high risk of leaving them infertile. So we take a whole ovary. So if we did decide to do this for the patients, we remove the whole ovary. And because it's difficult, if we were just to take the biopsies, we would get very little tissue, or we would actually, if we took a lot of it, risk that you had like bleedings. and then you would have to close those breedings, and then you would actually boil the ovary. So it's difficult to just take biopsies. I know some in Germany, they take mostly cortical biopsies, but in Denmark, we take the whole ovary to avoid complications, and because it's high-risk patients, so there's a high risk they will lose their fertility anyway. So we take the whole ovary, never biopsies. Yeah.
What's your experience? Microphone, please. Please.
Yeah, usually, well, in Verona, we usually do a biopsy, but they are a bit older, so maybe it depends also on the dimensions of the ovary, I guess.
Yeah.
Maybe.
La maggior parte di la
The-
maggior parte dell'ovale.
And yeah, well, in the end, it's the majority of the whole ovary.
Yeah.
Even
Okay.
if we do the biopsy, but it's still part of it,
Yeah.
2/3 of it, yeah.
Okay.
Usually.
Yeah.
At our institution, we used to decide which quantity to remove according to the age, and most importantly, according to the chemotherapy she's undergoing to do. Because, you know, there are some protocols which are associated with 100% of menopause. On the contrary, lymphoma, for example, has a very low chance of menopause. And so my opinion is that probably single ovariectomy may be damage much higher than what chemotherapy can lead to.
Yeah.
Yeah.
And I think in Denmark we've been doing this for 25 years, and it seems like the surgeons, they are just most comfortable by removing the whole ovary. But I do think we should differentiate between the patients, and some of them are not at that high risk, and it makes sense just to take the biopsies if you have a surgeon who are comfortable with that. So I think you can differentiate between the different patients, and I think it's a fair approach to do that too. It's just something we haven't changed in Denmark.
And also, if it's not only a chemotherapy candidate, but also a pelvic radiotherapy, do you also move the other one, maybe? Transposition? No. you
No,
do that.
not really. Rare cases. But that's, that's normally, then there's still some scatter radiation, and then you're not that good off. So we don't use the transposition very often, no.
Thank you.
Thank you.
As we are speaking of attempts of improving the outcome of ovaries, I'd like to have your opinion of administering PRP to the ovary. I'm sorry.
I love
I'd
that
like
one.
to
No,
know.
that's great.
Please.
Do you do it? Oh, thank you. I was a bit biased, yeah. Yeah, no, I don't think I've seen very good data on the PRP. And there's also a lot of physiologically challenges, I would say, with that approach, that you kind of inject these volumes of PRP in an ovary. There's no room to really inject anything. So it's not going to hang around for a very long time. So what kind of, the few studies that actually shown some kind of effects from this can equally be from just doing that mechanical injury to the ovary that we've also seen in our study. So it's not really the PRP doing it, probably it's something else, that just mechanical disruption. So I think it's become extremely hyped, and I cannot recommend it. We haven't seen any good data on this. So thank you for that question.
May I comment on this? So finally, there's a proper RCT published in HR recently from US, and so didn't show any benefit. Okay, so that's one, and I don't see the biological rationale. And thirdly, it is invasive. Right? So I've seen patients who were given PRP, then had to undergo emergency surgery, even lost an ovary. I've seen patients who became infected after PRP, harm the ovary. So it's not like giving, DHEA, okay, so if it doesn't work, but it doesn't harm, right? This is an invasive procedure with an extremely shaky biological rationale, right? So philosophically, nothing can be good for everywhere. I mean, people inject PRP for hair loss, people inject PRP for like whatever, wrinkles. The orthopedicians started it 20 years ago. It's one of the things that I'm really most intrigued. So 20 years ago, more than 20 years ago, it started with tendon injuries and muscle injuries in orthopedics. It took the orthopedicians 20 years to run proper RCTs and understand that it didn't work at all, even for the muscle and the tendons. But luckily we had this study earlier on now, and I never done it. I will never do it. I mean, and I don't think anyone doing it is doing something good for the patient. It's risky. No proper data suggesting benefit. The only proper RCT suggesting it's not beneficial.
There is a study going on in Germany, and every now and then I get some patients from them. They do not proceed there, but they come back. But I don't see any difference. I see what you said, the risks.
I was looking for questions from the audience, but I mean, I think we answered. This one is related to question to Professor Baris. I think we said, in luteal phase stimulation using PPS protocol, what is the incidence of premature LH surge? In general, we use Dufaston, but we observe high incidence to LH surge compared to generation antagonist protocol. I think we said on this.
So, I mean, if you've seen in the slides, we are not monitoring LH. We are monitoring even FSH, but not LH in any cycle, because as long as the patient does not ovulate, an LH surge or surge doesn't matter. I mean, there are studies, actually, even we did it. I mean, we didn't publish it lazy, but yeah, so as long as the patient doesn't ovulate, the LH, I mean, rising, falling, etc., doesn't matter.
Okay, so with this, we close the session. Thank you very much. So just a few words from my side. I'm very happy for the day. At the beginning, I thought it was an interesting day, but it has been really impressively interesting. I heard many new ideas, concept things. I felt your enthusiasm, and so I want to thank you again for being here today. I want to thank again Medea and Livio Casarini, my co-chairman. If you want to say a few words, please.
Yes, thank you. First of all, I would like to thank you for the support in this new experience. I hope that this conference, this workshop was very helpful to you that every day do research or clinical activities. This is a message also for our online audience. And also I would like to thank Medea, Merck, that always support this kind of event. So thank you all. That's all. I hope you enjoy it and have a nice evening in Italy.